Hello, and welcome to the RSNA Radiographics podcast. I'm your host, Leila Rezai, a cardiothoracic radiologist from Virginia Commonwealth University. As you may know, November is COPD and Lung Cancer Awareness Month. In recognition of those, we are going to discuss Dr. Scott J. Adams and colleagues' article, which is published in March 2024. The title is Radiographics Update: The 10 Pillars of Lung Cancer Screening, Rationale and Logistics of a Lung Cancer Screening Program. As the title indicates, this is an update to a previously published article in Radiographics in 2015. Let's remind ourselves of the 10-pillar model of an effective LCS program, which was introduced in 2015. Eligibility, education, exam ordering, imaging acquisition, imaging review, communication, referral network, quality improvement, reimbursement, and research frontier. The purpose is to present a brief update on key LCS developments since 2015 and their relation to the 10 pillars. Pillar 1, eligibility. In March 2021, the United States Preventive Services Task Force, USPSTF, expanded LCS eligibility by lowering the age threshold from 55 to 50 years and decreasing the pack year threshold from a 30 to 20 pack year smoking history. This expansion resulted in a larger proportion of individuals becoming eligible for LCS across all demographics. However, a recent cross-sectional analysis using a survey database from 20 U.S. states found that African American and Hispanic individuals remain less likely to be eligible for LCS compared with the white non-Hispanic individuals. To address this, additional lung cancer risk models may help reduce racial disparities. For example, studies showed augmenting the USPSTF age and pack year criteria with a model such as life years from screening with CT, also known as LYFSCT model, nearly eliminated disparities for African American individuals, unfortunately not as effective for Hispanic and Asian Americans. Further work is required to define equitable eligibility criteria. Pillar 2, education. Education of patients and healthcare providers on the benefits of LCS is critical for equitable uptake. A 22 report indicated that only 5.8% of eligible Americans had been screened for lung cancer. This is not the case for some of the other cancer screening programs. The average adherence of LCS programs is also low at 22%. Barriers to equitable LCS engagement include lack of awareness, fear of a cancer diagnosis, smoking-related stigma associated with lung cancer, out-of-pocket costs, and limited accessibility to imaging sites. Proposed solutions to barrier to equitable LCS engagement have been studied, including mobile CT units and ride-sharing services to overcome distance and transportation barriers. Non-stigmatizing terminology, such as lung health check, and dissemination of multilingual information about LCS. Training community members as community health advisors may also increase LCS participation. Pillars: examination ordering, image review, communication, and reimbursement. In 2015, a decision memo from the Centers for Medicare and Medicaid Services, CMS, determined that LDCT was a covered benefit for eligible adults, but stipulated that beneficiaries first undergo a billable counseling visit for shared decision-making with an MD. To facilitate LCS in 2022, CMS specified that shared decision-making can be provided by non-practitioners. In addition, radiologists no longer need to be involved in the supervision and interpretation of at least 300 chest CT acquisitions in the past 3 years, and the need to participate in a national registry was also removed, all to increase LCS uptake. Structured reporting remains key to guide management and optimize outcomes of LCS program. In November 2022, Longgrass update came out addressing atypical pulmonary cysts, juxtapleural nodules, airway nodules, and infectious or inflammatory findings while clarifying stepped management. The update also clarifies use of S modifier for clinically significant findings unrelated to lung cancer. Pillar 7, Referral Network. The important role of the patient navigator programs among vulnerable populations has been shown to improve screening rates, increase compliance with follow-up, decrease time to treatment, and increase patient satisfaction. Multidisciplinary clinics, staffed by radiologists, thoracic surgeons, radiation oncologists, medical oncologists, and pulmonologists, enhance the care of patients with lung nodules by streamlining care and increasing adherence to management recommendations. The emergence of virtual clinics introduced during COVID-19 pandemic boosted participation and access to multidisciplinary clinics. Worth mentioning that multidisciplinary clinics have resulted in increased non-surgical management of screening detected lung cancers. Treatments such as stereotactic body radiation and percutaneous ablation. Pillar 10, Research Frontiers. Research in AI and blood-based biomarkers remains an important frontier, with the promise to eventually help refine selection criteria, inform personalized screening intervals, and risk stratify screening detected lung nodules. A large focus has been on developing regulatory approved commercial AI tools for detection and classification of pulmonary nodules, a much needed tool. AI tools may potentially be useful in other things, such as decreasing the number of follow-up investigations, identification and scheduling of eligible participants, and image reconstruction and denoising. This is in addition to opportunistic screening for coronary artery calcification, emphysema, sarcopenia, and osteopenia. In conclusion, the 10-pillar model continues to serve as a framework for developing and sustaining high-quality LCS programs while improving equitable lung cancer outcomes through early detection and management. I hope this summary helped promote the important role of radiology in the debilitating diseases such as COPD and lung cancer. Thank you and have a good day.